Welcome, everyone. I am so glad that you all have joined us for tonight's webinar. My name is Dr. Susan Rogers, and I am the immediate past president of Physicians for National Health Program. And I'm so glad you joined us here tonight to hear Dr. Farzon Nahvi and Dr. Abdul El-Sayed as they talk about America's ongoing public health emergency. Please take a moment to introduce yourself in the chat and put in your name, your state, and your relationship to PNHP. And please also note that we will have a Q&A function open during tonight's program, so feel free to submit any questions that you may have as we go on. Now I'm looking at some of the names coming in, and it's great to have so many new people with us tonight. We all know that the U.S. healthcare remains in crisis, both inside and outside of the emergency department. And we know that the answer to this crisis is clear: a publicly financed and privately delivered nonprofit single-payer national health program that would cover everybody living in the United States. As we say, everybody in and nobody out. Now, this year marks PNHP's 35th anniversary of fighting for a single-payer reform. And as we celebrate this important milestone, we are also reflecting on the many thousands of physicians, health professionals, students, and activists who have brought us to this point. And we are digging deep to engage the next generation of single-payer advocates who will get us across the finish line and win the kind of justice-oriented health system that we all need and deserve. Now, I'm delighted to welcome our two physicians, authors, and activists who are leading the charge, Dr. Farzon Nahvi and Dr. Abdul El-Sayed. Now, Dr. Nahvi is an emergency medicine physician at Concord Hospital in New Hampshire and a clinical assistant professor of emergency medicine at the Geisel, I'm not sure if I pronounced that right, I'm sorry, School of Medicine at Dartmouth. His recently published memoir, Code Gray, explores the life and death issues that define medical practice everywhere and the uniquely unjust way those issues play out within the context of U.S. medicine. Dr. Abdul El-Sayed is a physician, epidemiologist, educator, author, and the new director of Wayne County, Michigan's Department of Health, Human, and Veteran Services. He is a co-author, along with Dr. Micah Johnson, of Medicare for All, a Citizen's Guide. And in 2018, he ran for governor in Michigan on a progressive platform that included advocating for a statewide universal health program. Please join me in welcoming Dr. Farzon Nahvi and Dr. Abdul El-Sayed.
Thank you so much, Dr. Rogers. So excited to be with all of you tonight. We've got an amazing showing for an amazing book written by an amazing activist, fellow physician, and author. Farzon, I'm going to let you take it away. I know that you selected an excerpt from the book to share with us tonight. We'd love to hear it. And, if you can, read it and then reflect a little bit on why you chose to read it to us.
Sure. I'll start by saying I didn't select it. I'm always very embarrassed to read my own stuff, so I'll give it a shot, though. And nice to meet everyone, and thanks for coming out tonight. So this is from, I believe it's from chapter 13 in my book. And I'll say, on nearly every shift I work, I see patients who suffer from uncontrolled blood pressure and elevated blood sugar. They casually describe how they have their insulin doses and space out their high blood pressure pills, taking them not as their doctors prescribe, but as their wallets allow. Understanding the long-term consequences, knowing that skipping these medications puts them at higher risk for heart attacks and strokes, blindness and kidney failure, toe and foot amputations, they tell me that they have no choice. And so, unable to afford their expenses, these patients get priced out of their hearts and minds, eyes and kidneys, feet and toes. I've even seen patients forced to barter diseases for one another. I once cared for a young man who had recently been evaluated, diagnosed, and treated for a fractured wrist. Upon receiving the bill for that visit, he began experiencing chest pain, shortness of breath, palpitations, and a tingling around his tongue and lips. He had received the bill for his broken wrist only to have it precipitate a panic attack. Responsible for coming up with thousands of dollars he did not have, he ended up back in the emergency room. Our healthcare system had, quite literally, treated one illness only to create another. So, yeah, the book is a memoir, and it's about my experiences in medicine and specifically in the ER. And it's not necessarily a policy book. I'm not smart enough to write a book like that. But I don't think you could tell a story about medicine or show what the ER is like without bumping into policy. I think you take a couple steps, you have to stumble into policy everywhere you go because it affects us so much. And then that's just one of the parts of the book.
Well, I think you've very poetically laid out the context and the argument for so much of the policy that we all advocate for. I want to ask you, stepping back, not every doctor writes a book, and I want to ask you, what was the thrust behind writing the book? What were you hoping to do with this, intervention on the public narrative?
Yeah, I mean, I've done a lot of writing. I've written a lot of op-eds and pieces, newspapers, and then I wrote this book, and they're very different from one another. The book is kind of this personal exploration that I felt I needed to explore, and the op-eds are kind of these calls to action. But all of them, anytime I write, I think it's not even so much that I choose to write, it's that I get to a point where I feel that I need to write. I didn't decide to write this book, for example. I was just walking through the park one day with my dog, and it just felt compelled to tell this story that was mulling over my mind, and I didn't realize it was bothering me so much, but it was a story about Lola, who is the backbone of this book. So I just ran to the nearest doorman building that day. I was in Central Park, and I think the doorman thought I was having some sort of emergency, or I said, I need some paper now. And he gave me some paper, and I just wrote a few pages, and that became the backbone of this book. And it just grew and grew and grew until it became what it was. So I think it all comes from this need to kind of urgently share the things that we see, because we see a lot of things that we're privileged to see, and they're just strong experiences, and the diversity and the breadth of the human experiences that we're privileged to seeing is profound. And one of the things that struck me when I got into medicine is how we're all witness to these profound experiences, and yet we walk out the doors of the hospital and we just don't talk about them. And it seems so insane to me. I think we need to talk about them for so many reasons, to understand them ourselves, to share them with other people so that people that are not privileged to it can understand, and also to change things and make them better. Because if people saw how bad things were and how crazy things are, I think they would feel more compelled to do something about it.
I really appreciate that point, because I think sometimes when you work in a field like this one, you are around a lot of people with shared experiences, and it makes you think artificially that everyone shares your experiences.
Yeah.
When in fact you are actually a small group of people imminently connected by those experiences, who actually have fundamentally different experiences than most people. And it's interesting because the challenge with public discourse is understanding what other people see and understand. And to make an effective intervention on the public discussion, kind of have to have an empathy for what other people understand. And I think sometimes we forget that a lot of the front row seat that we have to the human drama isn't a natural inheritance for most people, but it is for us. And we have a responsibility to feed that back to people. It's not just a choice. And what I really appreciate about what you shared is that, it was a need. It wasn't just I might write a book someday. It was
Right.
I got to tell the story. I have to tell the story. And I do think that it's instructive, because I think all of us carry stories from the front lines of human experience that tell us a lot about what we ought to do, what we are, and what we want to be.
Yeah.
And I really appreciate you doing that in this book. Tell us a little bit about Lola. Like, what was it about her experience in particular that forced you to want to do this?
Well, for the people listening, Lola's she was a woman in her 40s who came in cardiac arrest. Paramedics brought her in. She was coded before she arrived. We tried to resuscitate her and we failed, which is not an uncommon scene in the ER. Lola's story stuck with me. It struck me because it was one of those unique experiences, but also common at the same time that we have in medicine, where we are encountering a situation where it just feels just a little weird and you're not sure quite what to do, and you got to make a decision anyway, which is the backbone of medicine. But in this particular case, what happened was she had coded, she died, and I was very comfortable in terms of medically pronouncing a time of death. But then just as I was about to do so, the paramedics kind of whispered in my ear that, hey, the husband's about to come in any second. And for whatever reason, I felt a little weird about that. Usually the family members are either in the room the whole time, or they come in hours later and we take them to the family room. But this time, I just felt very kind of humanly terrible to have him walk in as we pronounced a time of death and kind of walked away from her. So I made the decision to continue on just for another 2-3 minutes, continuing the code, so that he wouldn't have to walk in under that circumstance and see that happen. And it was just a very instinctive, quick decision. And then for weeks after that, I just kept mulling over because it felt so weird and so wrong in its own way, just because I realized, in a sense, I was effectively making the decision to continue on someone who I knew was dead as almost as medical theater. And it just felt so weird to me. And I kind of second guessed my initial decision to protect him by doing that. That said, kind of this action felt so bizarre. And it kind of laid the groundwork for the book. The title is Code Gray, and it's all about kind of these gray areas of, you don't really walk away saying like, yeah, I got that right. I nailed that. You kind of just walk away saying, I kind of did the best I could, but it didn't, whatever action you take sometimes doesn't feel that great.
For those of you who have questions, please do drop them in the Q&A function. We'll take 1 or 2 of them or 3 of them as we move forward. I want to stop there for a second, because I really appreciate there is a subtle nuance in what you shared, and I kind of want to draw that out simply because I don't practice, and I made a choice to walk away from clinical practice before I even did a residency. One of the things that I always found so uncomfortable by the culture of medicine is that we were so comfortable drawing a red line between what was clinical, i.e. evidence and scientifically based, and what was human, except for all of the science that we talk about exists in the bodies of humans. And we sometimes forget the nestedness of it. We want to say science is here and feelings are here. But actually, science is here and feelings are here, right? And all of this is nested in people, and it's people's experiences in the end that are often the most lasting. And sometimes, you find, particularly in the harder specialties, no offense to the surgeons on the conversation today, that you draw very big lines between them, right? Because oftentimes in some practices you don't necessarily have to look your patients in the eye while you're doing what you do. And so I want to ask you about that differentiation. What of that do we do to protect ourselves and protect our patients, and create, leverage the sort of power differential that we have by being sort of the arbiters of the medical side, but not necessarily the human side. And what of that is just a function of being able to practice correctly? How do you square that as someone who has to make human decisions leveraging evidence every single day?
Well, I think a lot of it's protective, because I don't think the latter part, whether it's kind of you never have to choose between the hard sciences and the facts and the medicine or the human side. Those things aren't mutually exclusive. You could always do both of those things. So I think when we're ignoring these things, or we feel uncomfortable or doing the wrong things, I think very much, I don't even like to use the word protective mechanism, because I don't think it works. I think it's a protective attempt. I think that we think that we can protect ourselves by splitting these things, or not recognizing these things for what they are, these experiences. But I don't think you can have an experience which you're deeply part of, a very human experience with someone, and then by not addressing it or not thinking of it, you're protected by that. I think that's why we might have or part of the reason we have a lot of problems in medicine. I think a lot of people end up coming to a place where it becomes a little too much. And I think if you just think about it reasonably, I mean, you don't get immunity against emotions by kind of just seeing them over and over. They compound and they build. I was actually talking about this with a friend of mine a few weeks ago. And I was actually encouraging her to write. She's an ER physician in New York. She's brilliant. And she was telling me that she can't write because she doesn't remember the stories. She says, the moment I walk out of the ER, I just forget the stories and I just can't remember them. And then we ended up talking for an hour, and then she kept telling me the stories and these stories and these stories, and she kept drawing on every detail of every story. And then we were talking. I said, Jenny, you remember all of these stories. You just kind of push them away. They're not at the front of your mind, but they're all there. And thinking that you don't remember them and not addressing them doesn't mean that they're not still deeply in there. They don't go away. And I think the same is true in all of our experiences we have. And I think sometimes we act the way we do, largely because we just don't know to do better. We don't really consider it, because I think a lot of medicine is just an apprenticeship. We do what people before of us have done. We look at how they do it and we do it that way, not really critically thinking about why or whether it makes any sense. So I'm not saying addressing these things or thinking about them is an end all or a cure or anything like that, but I do think it's important just to kind of understand what we're doing. I live in fear of practicing medicine in such a way that I see something traumatic and it no longer bothers me. So that's part of why I try to just remember that, oh no, this is really important. My every day in the ER is almost all of my patients' worst day of their life. And that's a weird disconnect to bridge. And you have to keep reminding yourself of that disconnect.
It was interesting, right? Because we often try and cut down the human from the scientific. But what's interesting is one of the disconnects that a lot of us have as advocates for better policy is that if we cut down the human from the scientific, what happens when we get from the human to the humans, which is the policy space? Yeah. and that becomes really hard because we forget that actually this is what exists in the space where people think emotionally about their own experience. And it requires us to have the imagination to understand how people engage with medicine outside of the way we do. And when the scientific side is not a black box anymore, right? We get lost in the scientific side and then we almost forget the human side, which leaves us sometimes lacking the empathy to have a conversation that appeals to people's hearts and minds rather than just their minds. And sometimes the space where I get frustrated with fellow activists is folks we just nailed the empiric argument, right? And we're like, that's great. The empiric argument is fantastic. Don't get me wrong.
Yeah.
You can tell people how great it is in Canada all day. The problem, though, is that most people haven't lived in Canada. So it doesn't really connect to their experiences. I want to get to a second question. But first, if we may, let's move to a 1-minute video or a video from our friends at PNHP.
Thank you, Dr. Nahvi and Dr. El-Sayed. My name is Dr. Laura Helfman. I'm a longtime member of Physicians for National Health Program, and I practice emergency medicine in North Carolina and Tennessee. It is very exciting to be having this conversation. Our mantra in emergency medicine is that we are there for any patient, anytime, anywhere. This makes our field very rewarding, but it also has placed us under tremendous stress these past few years. The inequities of our profit-driven healthcare system have driven our safety net to the breaking point. I see it in the eyes of my colleagues daily. I've been thoroughly enjoying Dr. Nahvi's book and can't wait to finish it. If Code Gray piques your interest, then I'm happy to tell you that we have a special offer for PNHP supporters. If you donate $50 using the link in the chat, then you'll receive a signed copy of Code Gray. If you're not yet a member of our wonderful organization, we'll include a 1-year membership as well. I am personally a member of PNHP because it gives me the opportunity to join with like-minded colleagues to fight the insurance companies, the private equity firms, and other profiteers who are causing so much harm to my patients and preventing me from doing my job. I urge everybody to take advantage of this special offer, to read and get inspired by Dr. Nahvi's memoir, and to join me in organizing to win single-payer Medicare for all. Thank you.
Thank you, Dr. Helfman. That was a lovely message. I want to pick up here on a question from one of our
Can I
viewers.
interrupt before we do that, Abdul? Because I want to go back
Sure,
to
please.
what you were saying, because you're totally speaking my language. And I think it's a really important note to kind of reiterate and talk about, where it's talking to other people versus talking among ourselves. And I think it's not even just, I would take it a step further than you. I think the way we're trained is counterproductive when we're trying to communicate with a larger audience. I think if you came up to me and you told me that, my cousin used this acne medication and it worked really great. As a doctor, it's, who cares? Where's the data? Does it work or does it not work? But if you're trying to talk about health policy and you start talking about inferiority trials or numbers and statistics, people tune out. They don't care. You have to talk about the human stories. You have to get this across in that way. Otherwise, people don't care. So I think we're often trained out of being effective communicators with this stuff. And I think it's tremendously important what you said. So I just wanted to reiterate that. So thank you for bringing that up.
No, I really, really, really appreciate it. And I think when I teach this stuff, I always tell my students that we're in the process of being mismented, right? It's not that you have all your faculties. Your mind is being twisted to engage empirically. And yes, empiric reasoning is a fantastic way to make great decisions probabilistically, but it's not a great way to explain to folks, because we came up in the time when empiric reasoning was not possible, right? Our brains evolved to understand stories, not to understand empiric reasoning. I mean, it's only about 300 years that we can empirically reason at all, and probably only about 50 years that we could reason at this particular level, right? So we're not built for this. And we forget that, like, you have to go through years and years and years of school to understand exactly what it means that you had some sort of nested analysis, right? That's not a thing that most people understand. And the problem with the word analysis, right, is that the first four letters spell anal, and people don't take you all that seriously. So,
well, I just also want to point out that anyone listening, don't take my word for it. Don't take Abdul's word for it. Think of any smart people with MBAs, right? When you make a healthcare ad or you do a pharmaceutical ad, when you're watching an ad for any drug company, they're never going to tell you the statistics on the drug. They just show an ad of someone in a meadow that's saying that, I used to have knee pain and now I don't. And companies wouldn't spend millions of dollars on those kind of ads if they knew it didn't work. So don't listen to us. Listen to the smart people.
That's right. Got a question from Cheryl Banapps. I'm one of the many patients who had a negative medical and mental health experience. How can we, through our lived experiences, gain insights on the failings of our system? How can we get this valuable information out there to help guide those who are designing our national healthcare policy, so that no one else goes through what we do and has to suffer as we do? I'm basically asking this question here in the spirit of March Madness. I'm trying to throw it up and you can slam it down.
Well, I mean, I think it's an easy one for this audience, right? Because this audience is mostly healthcare professionals, I imagine, that are listening to this. And people desperately want to hear from us. And I think people come up to me sometimes, they say, you've written a lot. How can I get involved in that? And my answer is always, you just got to do it. People are desperate to hear from you. There's not much more to it. So I think we just need to share our experiences over and over again as often as possible to get things to get out there and change people's hearts and minds, because we all have these experiences. But again, just as we're talking about how we're privileged to the experience in the ER, not everyone interacts with the ER, interacts with medicine every day. Most people are young and healthy and don't go to the doctor all the time. They have insurance and things aren't so bad for them, but you have to share these experiences of when things get bad, how things really are, for people to really get it.
I want to ask you something. You're not on Twitter.
I'm not on Twitter.
Why?
I'm not on any social media. I don't even have a Google account.
So I mean, I'm asking a very serious question, insofar as there's something about being able to plumb the depths of an idea when you haven't been taught to parse your ideas in 280 characters. And in reading your writing, I think you do an amazing job offering, poetry and prose. And I want to ask you, there is this move to communicate in this sort of frenetic, internet intermediated way.
Yeah.
And you're making an active choice not to do that. Why is that the case? And how do you think that changes the way that you think about and then try and communicate your thoughts out there?
I think you hit it on the nose with thinking about and communicating. I used to work for Facebook in 2007. I lived out in California and I worked for Facebook.
Back when everyone thought Facebook was going to be awesome.
So I used to have all the technology and smartphone and all that stuff. I got rid of that stuff a while ago, maybe 4 or 5 years ago now. And it was very much because one time I was in an elevator and the whole elevator ride was probably 45 seconds. And I just instinctively went to my phone and I went to the New York Times and I was reading an article and I didn't even finish it. And I realized at that moment that I was more well-read than ever. I knew what was going on in the world better than I ever did before, but I was no longer having thoughts. I wasn't analyzing them and really thinking about it. I was just being informed about it. And I felt very uncomfortable with that. I didn't like, I thought it was much more important to maybe know less and think more about the world. So I got rid of all that stuff just to be able to get my mind back. And I take that approach a lot of it with my advocacy too. I always feel a little bit funny when I speak in organizations like this with PNHP, because I know that most of the members that are part of PNHP and most of the people that I work with know far more about policy than I do. They're much more informed and educated than I am. So I always feel a little self-conscious talking in organizations like this, but at the same time, I take a little refuge in just knowing that I'm able to share these stories. And I think communicating these stories and thinking about them in a different way is at least what I can offer, even if I'm not as well informed.
I think to your very pithy way, we've traded thoughts for takes, right? And I'd much rather have thoughts than takes. I want to move now.
That's a hot take. I like that.
Thanks, man. Thanks. Somebody should tweet that. Let me just get that on Twitter real quick. I want to move to another question from Simon, who asks, how do you avoid moral injury in a setting of the for-profit healthcare system we're presently in? And if I can twist that a little bit, there's a lot of pain in what you wrote, and I actually think that the ability to engage with that pain is one of the most powerful things about the book. There's a difference between pain and injury. That's one of the first things you learn in medical school, right? Pain is actually productive until it's not, right? And I want to ask you how A, was the writing process a means of soothing your own pain? But B, how do we tell the difference, right? Because I think sometimes we're taught to just eat the pain as part of the job. It's part of the culture, right? And we're not able to differentiate productive pain from fundamental injury that you can't come back from.
Yeah. So what was part A again?
I'm sorry?
You had a 2-part thing. I forgot the first one.
No. How do you avoid moral injury in the setting of the for-profit healthcare system we're presently in?
I don't know that I do. I think I'm very much part of it. The book, like you said, was very much me processing all of these experiences kind of net. It's a very broad book that touches on a lot of things. And I think for sure, 100%, the process of writing it was just very useful for me in helping me understand, even not coming up with any answers and not coming up with any solutions, but understanding what I was even thinking. I don't think you can go through our healthcare system without experiencing moral injury, just because it's thrown at you. It's part of the system. I recall an episode I had that really I remember very deeply, and I was going into an overnight shift at the hospital I worked at in New York, and there was 30 people waiting to be seen. We were very understaffed. Patients didn't have vital signs, and they were waiting for hours, and it just looked and felt chaotic. And I remember just kind of taking a survey, because I knew in a few hours I was going to be the only doctor there. Everyone else was going to be going home soon. And I just saw this elderly lady who just didn't look well. So I just grabbed the vitals machine and got her vitals myself. And she was tachycardic and hypotensive and had been sitting there just without even vitals for a few hours. And I called the administrator on duty that night just because it was just so awful that moment. And I said, hey, let's call him Mike, like, hey, Mike, I think someone's going to die tonight. This is just beyond the usual shit show. We're just so understaffed to the point that we don't even know who's sick and not sick. We can't even triage because we don't even know who to triage because we don't even have vital signs. And it was striking to me because a lot of times when I speak with administrators, we know the data. We know that understaffed ERs are correlated with higher mortality rates, right? We know that when you're understaffed, people die. But they try to finesse it and they say, no, we're good. The numbers don't justify this or that. We're okay. But this time I said, hey, Mike, I'm afraid someone's going to die tonight. And he said, yeah, I'm looking at the whiteboard too. I agree with you. I'm a little worried about that. So I said, what about calling some more nurses and what about getting some more staffing? He says, no, we don't have that in the budget. So there's the recognition that someone's going to die. Someone might die. There's the statement from the administrators that there's no money in the budget. And then I remember walking out of that shift and it was in New York. So you just see billboard after billboard, bus stop, subway stop, the little flags that sponsor a neighborhood, and they all had advertisements for the hospital that I just walked out of. And it was just this striking thing where you think that the same people who are running the hospital, they know that patients will die unless we get more nurses. And yet they choose not to spend money on the nurses. They say, that's impossible. We can't do that. And yet there's millions of dollars to be spent on every other piece of nonsense. And then you realize there's a system that just is beyond repair just because the incentives don't make any sense anymore. Because if you ask the administrators, hey, this is insane. Why are we spending money on ads when people are dying and we know that? They'll say, no margin, no mission. We're doing the right thing because we need to have these ads so that we make more money so that we could then take care of more patients. And effectively what you're saying is hiring nurses to save lives is negotiable, but spending ads is not negotiable. We have to do that. And then you have that saying, no margin, no mission. You could really justify anything. So if you're part of that system and you're working really hard, you're running around like a chicken with your head cut off just to keep people alive, and you realize there's all this money going on other things, you can't not experience moral injury, in my perspective. You can't put all this effort into keeping people alive and know that the institution you're working for is not meeting you halfway. That's tremendously difficult.
I got to ask you, because I literally left clinical medicine because of an experience in an ED with a resident who was post-call, who did not want to be there, did not want to admit a patient who fundamentally needed to be admitted.
Yeah.
And I decided I didn't want to be a part of the institution for exactly that reason. I didn't want to be in a situation where I could not do the work, or I was fundamentally opposed to the institutions in which I was trusting to do the work. And since I've been in medicine or been in medical school, it's been about almost a decade now.
Sure.
It's gotten way worse.
Way worse.
Fundamentally worse, foundationally worse. And I guess the question for me to you is how do you, or what do you do to make the circle square? How do you negotiate that fundamental frustration that is like existential to the practice of medicine in America right now?
No, the problem for me is that I love my job. I love emergency medicine. I just hate everything about the rest of it. The way I kind of made this analogy to a friend of mine once, it feels like, imagine some brutal, awful dictator has a private fire department service that he controls. Being an ER doctor in America feels like working for that fire department, where if this brutal dictator told you, put out this fire, but don't put out that fire, the act of putting out fires is good, right? Anyone that's burning in a fire that needs to be saved, you save them and you could feel good about that. You could feel like you're doing a good thing. And yet you recognize that something bigger is problematic. That's how I feel working in American medicine, that my day-to-day job, I feel good about what I do because I know that I'm able to help people. I sit down with them and I talk to them and we have that interaction, and that does feel great. And I don't know that I could get that anywhere else. And yet I recognize that I'm working for a system that says, take care of this guy but don't worry about that guy.
The other thing that I think you're doing, and I think everybody, the other 377 people on this call right now are doing, is advocating for a system that's better.
Yeah.
And I want to ask you, right, because writing this book is fundamentally an act of pushback, right? It's saying this system is broken. I am sitting here between the grinding wheels, and I am fundamentally frustrated, and you should be too.
Yeah.
How there's a question earlier about narrative medicine. How should we be thinking about the storytelling that we do as part of our clinical practice and part of a way of trying to make that circle square?
Well, I think there's the recognition that people want to hear from us. They're desperate for these stories. And I think that there's also the recognition that anyone who has these stories is by definition an authority in telling that story. I think I've talked to a lot of doctors who express an interest in writing or want to write, but they have a concern for one reason or another that I don't want to say something that another doctor might disagree with. You're not representing the whole field. You're representing your thoughts. And believe it or not, most people usually agree with most things that you're going to say, because we do have these shared experiences. And it goes back to what we were talking about earlier, that this is how people who read these stories and listen to this stuff in the audience will consume this stuff, is through stories. So I think narrative medicine is the mechanism and the vehicle to communicate all of our experiences and have people really get what's going on.
I got a question here from Susan Steigerwald. Shout out to Susan from Detroit. You have thoughts about the presence of private equity and the for-profit entities in emergency medicine? Is there anything ER docs can do to fight against it?
That's an interesting question. Actually, it's funny. I have all this kind of disagreement with our system, to put it lightly. And yet I also recognize that I've only ever worked for not-for-profit hospitals that aren't these venture capitalist funded groups. So I can't even imagine what that world is like. I know that 60% of ER doctors work for private equity backed groups, which is, I think, insane to me for so many reasons. The fact that we're funding these groups effectively through tax dollars, the fact that there's no correlation between outcomes and how these hospitals perform, it's just nuts to me. How to push back? I mean, I think we do need to start thinking about these stories in narrative medicine as an intervention. I think narrative medicine is actually an interesting thing to me because I think people are talking about it more and more. But I think a lot of times when people talk about it, they talk about it as this therapeutic thing that doctors can do to avoid burnout and to help process their feelings, which I think is very important and very true. And it helped me a lot in that sense. But I think what people fail to talk about enough is how narrative medicine is probably one of the most important medical interventions we can do, because we spend billions of dollars on R&D and creating a new drug that might increase life expectancy by 3 months in some specific cancer patients. Or someone could sit down in a coffee shop and write a story that changes people's hearts and minds, that could help push policy and get things changed, that could save so many more millions of lives. So I think it's one of the lowest hanging fruits that we need to think of as more of a medical intervention to get things changed.
All right, I want to take another break to hear from another one of our PNHP members.
Good evening, everyone, and thanks so much for joining us for this essential conversation. My name is Diljit Singh, and I'm the Vice President of Physicians for a National Health Program, and I'm a practicing gynecologic oncologist. Tonight's conversation is really a reminder of what we all know. American healthcare is failing our patients, and practicing medicine is almost impossible, as many of us feel powerless to provide the care we know that people need. PNHP exists to reclaim the American health system. Working together, we can create a system that provides the life-saving care our country needs. If you are a physician, a health professional, a student, or a health justice activist, or all of the above, I urge you to join us in the fight for health justice. In gratitude for the time you've given us this evening, we have a special offer. For new members, you can join PNHP at the $50 level using the link in the chat, and you'll get a signed copy of Dr. Nahvi's book, Code Gray. If you're already a member, the offer is available to you as well. If you make a one-time donation of $50, you will get a signed copy of this meaningful and thought-provoking memoir. PNHP has been working for 35 years to achieve comprehensive health care for all, and we are closer than we have ever been. We need everyone on this call and all your justice-minded colleagues and friends to stand up, to speak out, to join together, and to advocate for single-payer Medicare for all. Working together, we can achieve the health care system we all deserve. Thank you.
Thank you so much, Dr. Singh. I want to take another question here about young people. One of the interesting things about writing a book is that you actually write it and then you wait a year for the thing to come out. And so you sort of thought the things that you thought, and then a whole year passes by. And so in some respects, I remember when the book came out, I was like, I should probably read this because it's been a long time since I wrote it. And what it is, though, is that you're sort of writing for the future. You're putting a thought out there. It's almost like one of those floating messages that you leave in the ocean. You don't really know where it's going to go, who's going to pick it up, but you really do hope that it gets to somebody in a particular moment, a particular life. And I remember being quite a bit younger and reading Paul Farmer or reading even House of God by Samuel Shebb. And those books had a particular resonance in a particular time. And I guess I want to ask you, as you write this book, how do you see it interacting with the future? What do you hope it shapes or informs in the mind of a younger person in a particularly meaningful point in their life where they're making decisions that may close some doors and open others?
Yeah, I'll start by saying that I didn't plan on anyone ever reading this book. When I started writing it, I thought it was just going to be a very kind of sophisticated journal. And I just wrote it really for myself, which I'm really happy about because I think it allowed me to be super honest and open. And if I ever thought early on that this was going to become a book that other people would read, I don't know if I would have made the same decision. So I'm really happy about that. And in terms of putting it out there for the future, I think one of the tremendous things that happened is that I wrote the book kind of just writing about my feelings about so many things just to explore them for myself. And I've gotten already so much feedback from so many people. And I'd say a lot of them were actually doctors and people within healthcare that are reaching back and saying, hey, this is what I was thinking too. Thank you for putting it into words. So I think for young people in the future, what I would hope is that it helps them see the reality of medicine for what it is as they go into it. Because I think just as you had your experiences, I imagine you didn't really know what you were getting into until you had those experiences, which is why you left or you didn't go into clinical medicine. I imagine you had a very different imagination of what clinical medicine was years before that episode. And I did too. I had no idea what I was getting into, to the point that I felt a little bit deceived, to be honest. I felt that my med school was talking about these platitudes. Meanwhile, I stayed on as faculty at that same med school. I did med school residency and I was faculty at the same institution. And I felt that the same people that were teaching me some things were the same people directly telling me not to do those things when I was attending. It's one institution. So there's a bit of deception there in a way. You feel a little angry. And I think this book, hopefully in its honesty, it could give people that are about to have those experiences a little bit of insight about kind of the reality of what they're about to go up against.
Yeah, I really appreciate that. I mean, as I read through it, I thought to myself, I really wish I had this, book like this as I was thinking about what I wanted to do. The experience in medical school for me was I had some amazing mentors and professors, and then I had a lot of mentors and professors who you always kind of knew they didn't want you to look past a certain point.
Yeah.
And you'd ask certain questions, and it was almost like one of those video games where you can't run past a particular point in the game, or like the Truman Show. It's like, what happens if I go extra far? They're like, we don't go that far.
Yeah.
We don't ask questions like that.
I call that the
be
3 why
happy.
expertise.
Go ahead.
I think that my undergrad, you talk to your professors and they were phenomenal. And I called them 5 why experts. You ask a why, you ask another why, you ask another why, and they encourage you and they have an answer because they've thought about it and they're excited about it. But in med school, I had professors, and at best they were 2 or 3 why experts. You ask 1 why, 2 why, 3 whys, they might get it. But like you're saying, you ask the 4th why and they start to get frustrated. They get angry at you for asking the question. Anyway, that's the same term.
No, I appreciate that point. And I guess, the majority of people on this call are in this field. And I know that the folks here are the folks who are willing to go to the 4th and 5th why.
Yeah.
And I want folks to appreciate just how important it is to have someone like that. I mean, I remember when I decided to pull my residency application, I had a attending tell me that I was going to come back on my hands and knees. And at some point I was making a joke about it, but I was like, why am I hands and knees? I get that. Like, I might end up coming back and begging for residency, but like, why am I crawling in this scenario? Like, has something happened? Like, thankfully, but it was almost this moment of, you have crossed this Rubicon. How dare you? Right.
Yeah.
Almost as if you're making a choice that's different than the one I made invalidates my own sense of my choices. And I just think that we need to be thinking way broader than that. And one of the things I really appreciate about this generation of young people is that you are watching the budding physician union movement out of residency programs across the country, right? The Brigham, Mass General just unionized. That is a big deal. And they're doing that work on behalf of all of us, right?
Yeah.
Because too many senior physicians have been okay with living off the final bits of a system that is being broken down and sold for parts, right? And these folks are saying, nope, not on our watch. This is the healthcare system, the future that we have to live in. And there's a great question here from our friend Jonathan. He said, how do we activate the young medical professionals and students who have little time for public policy and activism to realize their own future in the system? And I would say, I think a lot of them are a lot more active than certainly in my generation we were. And I guess, what can we do to spur them on? What can we do to empower them? What can we do, right, to de-gaslight them when everyone else is like, no, don't ask questions about where the money comes from. Don't do that. There's a clinical pearl I want to show you. This is so much more interesting. You can hear Rawls in this patient. I'm like, I can hear Rawls in the damn medical system, right? Like, so how do you engage with that, and how do you spur them on from the position that so many of us sit in?
Well, I agree with you. I think this generation has got it in a way that ours, and certainly ones before us, didn't, in the same way. I always remember I when I went to med school, there's all these physicians, the attendings that were teaching me, and they kept talking about the golden age of medicine. And I grew up, I sometimes had health insurance, sometimes didn't, sometimes was on Medicaid. So we didn't have a lot of access to medicine in that way. And I kept thinking, golden age of medicine for who? It certainly wasn't for me growing up, but they were talking about themselves and their careers as a physician. So that was an interesting thing for me. And I think the younger people now are even more gassed up than I was. I teach every Wednesday up at the med school, and I could say from experience that these students really are on a mission in a way that I'm very impressed by. And what I do to support it is just keep telling them that they're right. They often bring up points and ask questions of me as if I'm going to have an answer for, hey, this is broken. Why is it broken? And all I could tell them is that I don't know. It is, though, and you're right, and we need you to keep going to solve it. but just to, I think a lot of them get concerned that, am I misreading something? Am I missing something? And that someone must have an answer for this, because clearly it's broken. So who's fixing it? And the answer is that it's going to be you, because no one's on top of it right now.
It also strikes me that this is a generation that takes the fundamental brokenness of institutions for granted. No, in our generation, Farzon, I think you and I are similar age.
I think we're the same age.
How old are you?
I'm 37.
Okay, so I'm 38. And we were that last generation. We're what we call geriatric millennials. Like we're the first generation to have internet in the home, but like only barely. And like as we grow up, and I think our generation. I just think about my childhood, your childhood. We lived through the 90s. We made it to about 13 at the end of the 90s, right? I was 16 when the year 2000 hit. So for most of my life, it was those comfy years when we hadn't hit the hangover of the Reagan years yet.
Right.
And then all of a sudden in 2003 or 2001, we had 9/11, right? And that, I assume that hit you about as hard as it hit me.
Yeah.
And then after that, we went to war, which only just kind of ended, but then you have all this drone war. And then you had the Great Recession when we graduated
Don't
college.
forget
And
Hurricane Katrina.
Hurricane Katrina 2005, right? And we were in college, we were graduating college into the worst recession in American history. And all of a sudden you're like, wait, this isn't how it's supposed to work. But if you age somebody 10 years and instead of having turned 16, they were 6, right? In 2000 or 7 in 2001. And then they were 13 in 2008, right? And now they were early college during the pandemic. For this generation of young people, the experience of growing up has been, all these institutions that we've been told are there to protect us, are doing the right thing, have the right people in mind. They have failed at every juncture of our lives. And I just think that they see that. I want to ask you, as you think about your experience, your moment, and the sort of generational move, this weird position that we sit in, sort of between that quote golden age versus Gen Z, where everything was broken, or they watched it all break. What role do you think that like this sort of early career physician has in being able to be a narrative bridge and explaining one to another? Because I find myself doing that all the time.
Oh, yeah, that's interesting. No, I agree with exactly your sentiment. I remember I had a scribe that I work with a lot a few years ago, and she was about 10 years younger than me. And I kept thinking, it was during the election season, presidential election, and we kept talking about this stuff. And I realized somewhere deep down, as much as I had my own politics, somewhere I still believed that things somehow worked, and she did not. And I realized it's that 10-year difference to what you're saying, where she's never seen anything function in the way that it's sold as being supposed to. And I think that it's that lack of shared experiences, like you're saying, that doesn't allow them to understand the older generation to understand them. And I think we do live at that bridge. I don't know that I have anything more to say except to confirm what you're saying, and also to say that we do have a role in that bridge to kind of help these groups communicate with each other, because we've experienced growing up in that world, and yet we see this world for what it is.
So a lot of folks out there, this is the last question I'm going to ask before I turn it over to Dr. Rogers. There are a lot of folks out there who are thinking, you know what, I got to tell my story too. What is step one?
Step one is just doing it. Just start writing. I do want to say that I did not major in English. I've never been to a writer's retreat. I only just started doing it. And I started writing in med school, actually. And I just kept writing and writing because I had things that needed to come out. And then eventually I got some stuff published in journals and papers that no one's ever heard of, and it was exciting. But then you work with editors, you get better, and year after year, and then a few years later, you get better and you keep submitting. In med school, I would submit to, op-ed at NewYorkTimes.com with my op-eds, and I imagine it was just laughable, the type of stuff I was submitting. And I remember the one time in residency where I got my first acknowledgement of a rejection from them, that they emailed me back to say this was bad. And it was exciting because it said, wow, they actually took the time to tell me it was bad rather than just ignoring me. So I realized I was onto something. And then eventually you do get published in the Times, and you get published in other places, and you keep going and you keep writing. And in the beginning, it might be hard, but there's a process, and you get better and you just do it. There's nothing to do it but to do it.
I really appreciate the wisdom, the pearls that you shared in your book, the opportunity to come and share it with us here at PNHP. I just want to thank all of the organizers for all of their work in making this possible. Farzon is too humble to say it, but the book is excellent. And if you haven't picked up a copy, the way to do that is to make sure that you sign up at PNHP, and you'll get a free copy with a donation of $50. You can also, of course, order it, but the PNHP route is the way to go. Do something good for our healthcare system, and do something good for yourself, and do something good for Farzon too. So Farzon, thank you so much for taking the time. Thank you for your humility, your generosity of spirit, of thoughts, and of time.
Abdul, this was wonderful. It's great to chat. Thank you so much. And thanks everyone who tuned in and everyone for organizing. Have a great night.
Don't leave yet, but I just want to thank both of you. This has been just an incredible conversation that I've totally enjoyed. And I really liked how you brought up, Farzon, how emotions come in and as physicians interacting with patients. And I look back at my years at Cook County Hospital, where I saw patients at sometimes the lowest points in their life and with nowhere to go. And these memories don't go away. And I think it's important that they don't, because they are part of who we are. And I think those emotions are so important because we really understand why we need single payer. And it's those emotions that make us wrap our arms around single payer. And it's those of us with those emotions that have to make others aware of their own emotions that they may try to make excuses for. But I think that's what's kind of unique in our group, is that that's part of life that we need to fight for. So I want to thank you both for your enthusiasm and your sense of health justice. And I, for one, can't wait to get my copy of Code Gray. And I also want to thank everybody who tuned in tonight, whether you're a longtime member of PNHP or you're just now dipping your toe in the water of the single payer movement. But everybody on this call has a role to play in fighting back against the injustices of our current healthcare system. And true healthcare justice only will happen if we continue to organize ourselves as doctors, students, healthcare professionals, and activists to fight for it. So don't forget to sign up, contribute to PNHP, and you can receive your book. And I'm just so glad to see our movement growing and evolving. And although I'm only a year older than the two speakers who, since they said their age, I'll admit my age. I'm a year older, okay? But hopefully.
I thought you were 29, Susan. Wow.
Well, I'm senile. I forgot that. Thank you. But I hope that, you know, we will be able to finally see single payer in our lifetime. So thanks again for everybody who signed on the call. And thanks so much to Dixon and Lori and our staff and all the rest of our staff too for doing all the work getting this program together tonight. Okay. Good night, everyone, and thanks for joining.